There's a large lesion in the right suprarenal fossa showing foci of small calcifications. The abnormality displaces the kidney inferiorly. At this point, the lesion could be arising from the adrenal gland or from the kidney itself. The arterial phase of enhancement shows that the lesion has areas of heterogeneous hypervascularity. On the portovenous phase, the lesion shows more heterogeneous enhancement, and there is a suspicion of a filling defect within the IVC. Coronal images are very useful in assessing the origin of the lesion. If this abnormality arises from the renal parenchyma, this would be a renal cell carcinoma. However, as seen here, the mass displaces the kidney inferiorly and it's clearly separated from the kidney, so this is an adrenal lesion. The commonest adrenal lesions are adrenal adenomas, which are usually small and low in density. Whenever you see a very large mass lesion with heterogeneity, think about malignancy. The two major differential diagnostic possibilities here would be an adrenal pheochromocytoma and metastasis. Since this is an isolated lesion with no other foci of abnormalities within the CT, chest, abdomen, and pelvis in a patient without known malignancy, the major consideration is a pheochromocytoma. Both adrenal and renal neoplasms may invade into the adjacent IVC, either directly or via a tumoral thrombus. Remember how we questioned a filling defect on the portovenous phase? The coronal image shows it all. The adrenal neoplasm is well separated from the adjacent IVC. And what was questioned for being a thrombus turns out to be non-opacified blood returning from the IVC and mixing with opacified blood. This is a neat case with several teaching points. The first is always assess the center of the lesion and where it arises from. Coronal and sagittal images are useful. The second teaching point is that a heterogeneous and large adrenal lesion raises the possibility of a primary neoplasm such as pheochromocytoma or metastasis. The third teaching point is that you have to assess for tumoral thrombi with renal, adrenal, or hepatic neoplasms. The fourth teaching point is that flow artifacts from non-opacified blood may mimic a tumoral thrombus, so make sure you don't fall into that mistake. Well, that's it for today's case. See you tomorrow. I will leave you with one more question for today's case. We talked about pheochromocytoma and metastasis. What would be your third logical differential diagnosis for such a lesion? This is a quick case showing multiple findings. The first are these well-defined opacities that follow the rib distribution consistent with old rib fractures. However, the reason I'm showing this case is to emphasize on a very important point. You should always look at another hidden area, which is the retrocardiac region. Now you could see that there is an opacity that contains an internal air lucency and a probable fluid level. Once you see this, look at the lateral chest radiograph. You're going to see the same fluid level in a retrocardiac location. This is consistent with a small hiatus hernia. So remember to look at the retrocardiac area on both the frontal and on the lateral chest radiograph. This is a 68-year-old male patient who presented with loss of consciousness. This is a study without contrast that shows an extraaxial collection of hyperdensity. This is consistent with bleeding. When confronted with extraaxial bleeds, you need to differentiate between two types, the subdural hematoma and epidural hematoma. This is a case of left-sided subdural hematoma. The first feature that supports this diagnosis is the crescent-shaped appearance of the collection. This is in contrast to epidural hematomas, which have a biconvex or lentiform appearance. The second important feature to keep an eye on is that these subdural collections could span the brain from anterior to posterior, disregarding the osseous sutures. This is in comparison to epidural hematomas that are classically confined by osseous sutures. On the other hand, epidural hematomas may cross the tentorium and falx, while subdural hematoma like these do not do that. Notice that this subdural hematoma does not cross the falx cerebri or the tentorium cerebelli. Despite the type of intracranial bleed, it's always important to assess for the associated mass effect. There is significant mass effect in this case. The first sign of mass effect is the effacement of the sulci. Notice how the sulci disappear here compared to the normal side. Another sign of mass effect is the compression of the lateral ventricle on the affected side. Note how you could see the lateral ventricle on the contralateral aspect. Of extreme importance is to assess for midline shift. As you see here, the septum pellucidum is deviated by about 1 centimeter from the midline. Midline shift is also known as subfalcine herniation, as the brain herniates underneath the falx cerebri. Two other herniations to look for is the herniation of the brain through the tentorial incisura, also known as transtentorial herniation. To easily assess for this, check the CSF space adequacy around the midbrain. This CSF space around the midbrain is also called perimesencephalic cistern. The third important type of herniation to assess for is to check for the position of the cerebellar tonsils. In this case, the cerebellar tonsils are in normal location. However, if you see the cerebellar tonsils descending through the foramen magnum, in the context of a supratentorial lesion, you have to think about tonsillar herniation. So check for fullness at the foramen magnum. An easy trick to use is that the tonsils should not reach the level of the dens. An easy way to assess that, of course, is to look at the sagittal reform mass and to check for the level of the cerebellar tonsils. The teaching points from this case is to differentiate subdural from epidural hematomas and to be aware of the several herniation syndromes. See you later. This is a 63 heavy smoker who presented with hemoptysis. There is circumferential thickening of the lower trachea just above the carina, with an area that has a polypoid projection into the lumen. When faced with such an abnormality, it's important to assess the degree of airway narrowing, as well as the association between the lesion and the surrounding structures. The focal projection of the abnormality here raises the possibility of a primary tracheal tumor. A very important concept to keep in mind is that primary tracheal tumors are almost always malignant in adults. The major differential diagnoses would include squamous cell carcinoma, salivary gland tumors, and carcinoid. Carcinoid tumors are rare in the trachea and are more common in the bronchi. So this leaves us with squamous cell carcinoma and salivary gland tumors. Squamous cell carcinoma is typically seen in older patients. This is compared to carcinoid and minor salivary gland tumors, which appear in younger age groups. The risk factors for developing squamous cell carcinoma of the trachea include old age, smoking, and alcoholism. So the favored diagnosis here would be squamous cell carcinoma. Since the patient is a smoker, you should always assess the lung parenchyma to make sure that there is no associated lung cancer. Although the lungs did not show additional lesions, the parenchyma demonstrates centrilobular emphysema and areas of bronchial wall thickening. The presence of centrilobular emphysema and bronchial wall thickening are consistent with smoking-related changes. A very important point to keep in mind is that primary tracheal neoplasms may look focal. However, you should always assess other images, namely the coronal and sagittal reform mass, to make sure you evaluate the entire craniocaudal extent of the lesion. And as you see here, there is significant cranial extension of the abnormality, involving a length that is more than expected by just looking at the axial images. Such craniocaudal extension is extremely important to report since this affects the surgical planning and the possibility of tumor recurrence. The teaching point here is to remember the three differential diagnoses in an adult patient with a primary tracheal neoplasm. Again, the primary tracheobronchial neoplasms in an adult are squamous cell carcinoma, salivary gland tumors, and carcinoid. Our other teaching point is to remember to assess the coronal and sagittal images for the exact extent of the abnormality in a craniocaudal direction. That's it for today's case. See you next time. This is a CT on a 34-year-old male patient who presented with abdominal pain after liposuction. There is subcutaneous air which is expected after liposuction. However, the intra-abdominal free air is not a normal finding. Although part of the free air is intraperitoneal in location, a large amount of air is located in extraperitoneal spaces. There is a large air pocket that surrounds the pancreas in the anterior pararenal space. Also note the multiple air pockets that are seen in the anterior pararenal space and behind the left-sided colon. This is important to recognize since this gives us a hint that part of the process is at least retroperitoneal in nature. Given the presence of intraperitoneal and retroperitoneal free air, it is very important to look carefully for any possible site of bowel perforation. I'll give you another chance to look at the images as I scroll slowly. Closer inspection of the area surrounding the left-sided colon shows that it's not only free air that's seen in this location. There is adjacent hyperdensity, which is equivalent to the density of enteric contrast. Such a finding confirms perforation with extraluminal leak of enteric contrast within the retroperitoneal space. And by scrolling slowly, you'll notice that the area of perforation arises from the posterior wall of the descending colon. This was an interesting case that shows a rare complication after liposuction procedure in the form of colonic perforation. The first thing you learn from this case is that if you have free air within the abdomen, you have to look very meticulously for a possible area of bowel perforation. The other learning point is to recognize the distribution of air or fluid within intraperitoneal or retroperitoneal spaces. Localizing free air or fluid to a retroperitoneal space is very useful. For example, in the current case, recognizing the distribution of air made us look carefully at retroperitoneal structures. Well, that's it for today's case. Thanks for following us and see you later. There are small bilateral lung volumes. In addition, very fine reticular opacities are seen at the lung bases. The reticular opacities are easier appreciated on this magnified view. When in doubt, don't forget to use the lateral radiograph to assess for interstitial opacities. Notice how the retrocardiac area is crowded on this image, and it is more obvious on this magnified view how the opacities assume a reticular pattern. Whenever bilateral lower lung interstitial fibrotic disease is suspected, the two big patterns to think about would be usual interstitial pneumonia and nonspecific interstitial pneumonitis. UIP and NSIP may be idiopathic, however, a few important secondary causes should be thought about. You have to mainly exclude occupational lung disease in the form of asbestosis, connective tissue disorders, and drug reaction. Now, knowing that, have you noticed the soft tissue calcifications around the left shoulder joint? This is the CT scan of the same patient. The CT confirms the presence of bilateral peripheral predominant, reticular, and ground glass opacities. Expected associated traction bronchiectasis is also noted in an overall appearance that suggests an element of fibrosis. Note that the subpleural space is relatively spared despite the peripheral location of the abnormality. The presence of ground glass opacities in addition to reticulations, along with the subpleural sparing, is in favor of NSIP. Have you noticed the mildly dilated esophagus as well? And this is the soft tissue calcification that we saw surrounding the shoulder joint on the chest radiograph. Given the NSIP pattern, the esophageal dilatation, and the presence of soft tissue calcifications, the final diagnosis is scleroderma. Thanks for watching today's story. See you later.